A very good morning to one and all. Today I'll be presenting our findings on evaluating a new visual field strategy in relation to early optic disc changes. So as we know, static perimetry is the gold standard of monitoring progression in glaucoma, and the Humphrey Visual Field Analyzer 2 has full threshold fastback CETA standard and CETA fast algorithms. CETA standard and CETA fast were introduced with the aim of reducing test duration by 50% from the full threshold and fastback strategies respectively. In the Humphrey Visual Field Analyzer 3, we have the CETA faster strategy, which further reduces test duration by 50% from CETA standard. The current recommendations are to perform 3 perimetries for the first 2 years of diagnosis. And studies have also shown that testing the central visual field is sometimes useful in early glaucoma II. CETA faster is a strategy that incorporates 10 asymmetrically distributed test points from the 10-2 grid onto the 24-2 grid. The purpose of this study was to study the correlation of 24-2C CETA faster strategy results with the optic nerve head changes. It was a cross-sectional study conducted in a tertiary eye care center in eastern India from June 2021 to October 2021. We included patients of 18 years of age or over who were either untreated disc suspects or untreated cases of raised intraocular pressure. Patients with suspected or already diagnosed neurological problems were excluded from the study. At the first visit, IOP was measured by Goldman applanation tonometry, and patient was examined on the slit lamp with a 90 diopter Vogue lens for any presence of optic nerve head changes. Patients with any detected changes or a raised IOP were then subjected to stereophotography for obtaining image of the optic nerve head, and then visual field was done by Humphrey Visual Field Analyzer 3 in CETA faster strategy. In this image, we can see the central test points from the 10-2 grid on the 24-2 grid, and the right eye shows a few central as well as peripheral scotoma in early optic nerve head change. Statistical analysis, descriptive statistics were used, and Pearson's correlation coefficient was used to study the correlation between continuous and quantitative variables. 50 eyes of 28 patients were studied who had optic nerve head changes or raised IOP. The mean age was 44.5 years, and we did not obtain any significant correlation between any of the reliability indices or other values on the visual field report with the optic nerve head changes. The mean cup to disc ratio was 0.52, mean intraocular pressure was 19.48. However, the presence of dense scotoma in the visual field report correlated positively with presence of increased cup to disc ratio. A maximum of patients we studied had a normal or increased cup to disc ratio, with a minority also having some neuroretinal rim abnormalities. We did not study the correlation of false negatives with optic nerve head changes because there is existing evidence to suggest that false negatives do have a positive correlation with presence of glaucoma. The other reliability indices did not have any significant correlation. Majority of the eyes with optic nerve head changes had peripheral scotomata. Hence, the CETA faster may be preferred to the 10-2 grid in early glaucoma. In diagnosed cases of early glaucoma, it can be used to monitor central involvement. In advanced glaucoma, it may be used to monitor both central and peripheral involvement simultaneously due to lack of time. Mean test duration we obtained was 178 seconds, which is comparable with other studies which obtained Hale et al. Obtained 170 seconds with CETA faster, and both these are much lesser compared to the test duration of CETA standard. The limitations of our study were a small sample size, absence of follow-up, and lack of comparison with other field strategies. In future, this can be compensated for by comparative studies and correlation with optical coherence tomography findings. To conclude, with an increasing disease burden, the recommended frequency of follow-up and perimetry, the CETA faster strategy may be a time-efficient way to monitor progression of in peripheral visual field as well as detect early involvement of central visual field in glaucoma. Thank you.
Have you repeated the fields again to establish two good baselines?
Yes, ma'am. That was one of our limitations, that we did not.
And that is not been done.
Yes, ma'am.
So, first question, whether these patients were perimetrically trained or novice?
They were not perimetrically trained, so they were all patients who visited the clinic. Most of them were having a perimetry done for the
You
first
don't have
time.
data that how many were trained and how many were doing first time.
No, sir, but there were very few people who had any previous experience of perimetry.
Second, from your data, the conclusion, other than time, your data does not tell anything. So your conclusion should be based that only that it is time saving.
Yes.
Because you are not compared with the standard care, that is 24 days 2, or some people do 30 days 2 plus 10 days 2 when you are combining. Then you can say that it is matching up and maybe it's better to do. So your data was very limited and your conclusions way beyond your what data is showing, because your data is not showing anything. Okay, because you are not compared with the standard perimetry. The disc evaluation, how it was done, you are not mentioned. Who did the disc evaluation? I know you saw stereophotography, but who evaluated? Whether they were glaucoma specialists with how much experience. The patients were doing first time field, then there can be a learning effect. Though it can be within the false positive and false negative fixation loss can be within acceptable range, still the patient have a learning error. Okay, so whether if the first fields were not excluded, those all will come as limitation of the study. So the conclusion should be based only on data. Your conclusion goes far beyond what data is actually telling. Okay.